Andreas, one of the new things, it's really, actually, it was highlighted in this meeting last year. It was only 12 months ago. Great live case from the Glasgow group. An stent that they tried to expand, and it talks to Peter's point, they tried a 40 atmosphere balloon, were unable to expand this stent in a critical position in the proximal right coronary of a very heavily calcified vessel. And they used this lithotripsy balloon to expand the stent, and we saw it with our own eyes. While the lithotripsy pulses were being delivered, the stent being expanded. What do you think of this new technology, and how does it move us forward?
It's fantastic new technology, and it's fantastic to have that in the armamentarium. It's been a long time coming. Just talk through the principle. This lithotripsy we know from kidney stones, right? So it's a method to apply ultrasound remotely, but in a focused beam to disintegrate kidney stones, make them smaller so that they can go away. This principle is translated into a balloon inside the coronary artery, so you have to get a balloon in, and then aims at the calcium around the balloon, the calcium in the vessel wall. You apply shocks, the ultrasound in a sequence, and what it's supposed to do is it's supposed to disintegrate the calcium. It breaks the calcium bonds. It doesn't make it disappear.
So this is calcium deeper in the vessel?
The calcium doesn't go away, it doesn't move, is my understanding. It's just the bonds of the calcium. So rather than having one big chunk of calcium, it breaks apart. So you have little chunks of calcium, which then will enable expansion.
So we blow up the balloon, we administer these pulsed, focused sound beams. What does the patient feel during that?
The patient doesn't feel anything, really. This is ultrasound. If you block the artery with a balloon, you may get the usual chest pain, but it's short sequences, really. The pressure used is minimal. It's a small inflation just to bring the balloon in contact with the vessel wall, and then you apply the shock waves, and that's the name.
So essentially it's a simple balloon technology with this ultrasound within it?
With an integrated shock device.
So does it take a long time to do? Is it quick? Is it easy?
It is very easy. I mean, you bring a balloon into the lesion and you push the button.
Wow.
It is that easy. We have limited experience with it, but so far 100% success rate. It's a bit like, following rotablation, when a previously undilatable lesion, all of a sudden, the balloon goes up at 4 atmospheres, and that doesn't seem to be a problem whatsoever. I think a word of caution, we're still learning.
Right.
There's no data on the device. There's no data on the success rates. There's no data on the long-term results. All of that is coming. It's extremely promising, and I'm very, very happy that we have now access to this technology. But if you, for example, look at the first case that was shown last year, this is not in the instruction for use.
Yep.
And there are some things you just have to think about. For example, the ultrasound may actually interfere with the polymer drug coating of a drug-eluting stent.
If you're using it intra-stent.
If you're using it intra-stent.
Yeah.
So the jury is not out, but we have to think this new principle through, and we have to also rely to being informed by the company what is good and what is not.
And I was reading and listening actually to Carlo De Mario, who's been using it in iliac arteries.
Now that is clever.
Yeah.
Yes. So for the TAVI operators, this is a tool where what keeps us from putting the sheath up the iliac artery is very frequently just a little area or a short area in the iliac artery that has circumferential calcification.
Bottom of the aorta, just at the top
exactly,
of the iliac.
And you're not, it's not flexible enough. You just can't expand it. It hurts the patient. You cannot advance the sheath. And there are now numerous cases, and I've seen some in live cases and in reports where the same simple principle applies. You have the wire in, you put the larger shockwave balloon in, you apply the shockwave, and the ring of calcium doesn't go away but disrupts, and you are able to advance a sheath.
So going back to the coronaries, Colm, have you used the lithotripsy balloon?
Yes, I have. It's certainly a disruptive technology and very exciting technology. I think it will be complementary to rotablation rather than replacing it. Where I see a role for it is actually in the larger vessels, where to modify it with rotablation you would need to take it to your 2.5 millimeter burr. So for that deep wall calcium, it's ideal. I think scenarios where you've got a bifurcation and to use rotablation you would have to take one of the wires out of either the main branch or the daughter branch, and that's an uncomfortable situation for us, especially if that's a left main stem. So it will allow you to modify calcium having a wire in both branches. I think the underexpanded stent, and while that's not in the IFU, the only option for an underexpanded stent that has been deployed is rotablation, and that's really not much fun.
Right.
So while I accept that it will probably affect the polymer and probably strip off the polymer, certainly on the luminal aspect of the stent, I don't see that as a big issue in the long term. If it allows you to get a stent well expanded, you can put another stent within a stent. We do that all the time. So I see it as being a fantastic adjunct. It appears that you need a lot of circumferential calcium. So if it's like eccentric calcium and you need an arc of up to 270 degrees really to get effective effect from the shock wave. So what we do in Belfast is we mandate the use of imaging up front. And if you do not have 270 degree calcification, you don't use shockwave.
Yes, it's an interesting, I mean, it's ideal in some respects. The more severe the calcification, the more likely this technology is going to help you. And have you imaged after the stent deployment? What are your thoughts about the quality of the results that you've had subsequent to shockwave?
Yeah, it is certainly very, very good. We've actually used it in the CTO space in the subadventitial, where you've got a heavily calcified vessel, but the equipment is sitting outside the vessel, and it's absolutely no effect in that scenario. And it's basically the sound waves are heading out to the path of least resistance, which is the adventitia. Where you've got circumferential calcium and it modifies it very well. I think we haven't done anything to the coronary that's been as disruptive, in that, you know, the energy applied. So whether there's a consequent down the road in terms of restenosis from the injury, I think we have to wait and see. But there's certainly some early anecdotes of aggressive restenosis. So I think, for example, there's 80 pulses with each balloon, yep. 8 by 10. I don't think we should feel obliged to use all 80.
Right.
And I think the least number of shocks that you apply to the vessel to get the job done is what you should do.
So that's right. I mean, it was going to be interesting as to how this technology is incorporated into our practice, although actually, to a certain extent, you know, it's an example where practice has almost leapfrogged the clinical trials. So Disrupt 2, which is I think it's something like a 12-centre registry, European registry, is not yet complete, but many labs are using this technology to help treat calcified lesions.
And just we're reporting that this is mechanical energy which is then dissipated. So we've noticed that you will get ventricular capture or shock topics, and especially if the patient's heart rate is around 60 beats per minute. So what you will get is a capture from the shock topic. We don't think that is of significance other than it will cause hemodynamic compromise in some patients. So for the period of that shock topic, you can get a drop in blood pressure. There are also some reports of it interfering with the pacemaker interpretation. So you may have to reprogram your pacemaker to a backup mode. It's interesting that it is not gated. So if you go for extrinsic lithotripsy and get your kidney stones, that is gated, ironically, but the coronary device is not. So that is something that we need to understand, but there's not a noise that is going to be associated with a bad outcome.
Certainly our experience has been that it is very simple technology to use. The results have been very exciting, I would say. You know, we have seen really spectacular results, final stent results, which you wouldn't have got, I think, with standard technology. And I think it is going to change, I think, the way we approach some of these lesions going forward. And change our algorithm, perhaps, actually. You know, we've got rotablation, which ultimately starts in the lumen, and this therapy, which essentially is treating more the media and adventitial calcium. And obviously, I think the other thing to say about shockwave is that when we end up trying to treat a calcific ring, it's not infrequent we end up dissecting the vessel. And you've got that awful position where the napkin ring is still tight, but you've dissected perhaps before and after, which is clearly extremely dangerous scenario. So I think the predictability of response of this new shockwave technology is going to be something which I think is going to be valuable.
Well, the area that appeals to me most, though it has not been studied yet, is actually in the post-stent deployment. And I would make an argument for routine use of this to optimize your stent after it's put in. Now, that needs to be understood in terms of research with regards to the effect of the polymer. There's talk about pitting off the stent, but I think contemporary stents, and certainly if you've got an abluminal polymer, then you're not going to be effective in the luminal aspect. And I think if you then put in stents in a long, heavily calcified vessel using guide catheter extension, and then use the shockwave balloon to optimize your stent.
Well, certainly, I think there's no doubt that we can't be complacent about our results. I think that's what you're hinting at there, and something that your group are very good at, is not just getting the stents in and saying, right, take your gloves off, we're done. You know, you've talked a little bit about imaging. The need for us to we're never going to get perfect results, but the need for us to get really good results is very, very evident in this group of patients in particular.